So good evening, everybody, and welcome again to another round of an invigorating webinar series and session. And I will be introducing our speaker for today's session shortly. But just before that, just a reminder about SigTuple. We are a company who engage with robotics, optics, as well as data science to create smart solutions in pathology on digital-based platforms, as you all know. And without any further ado, let me go to introduce our exciting speaker for today, none other than Dr. Surbhi Singh. She is a hematopathologist from Agilus Diagnostics, Gurgaon. And as you can see, she specializes in bone marrow morphology as well as in flow cytometry. All of this is associated largely with Fortis Memorial Research Institute in Gurgaon, and she's here with us today to drive us through an exciting, invigorating session. And I think that which you will all really enjoy. Please have your questions, your comments in the chat box, and we will be more than happy to address all of that during the session and even after the session. And not to forget, there's going to be an interesting quiz, which Dr. Surbhi will be conducting, one question right at the end. So stay till the very end and participate. Your interaction will be most valuable, and the correct answers will definitely get a very special gift from all of us. So without further ado, on behalf of SigTuple, I welcome you, Dr. Surbhi, here. And please extend this warm welcome. The rest of you as well, please join me in welcoming her. You'll find her inspirational, dynamic, charismatic, and very knowledgeable. And I'm sure that you will enjoy today's session as well. Over to you, Dr. Surbhi.
Thank you so much, Dr. Renu, for such a kind introduction. Good evening, everyone, and I welcome you for today's session. I will, without further ado, I'll share my screen. Okay, so today's topic is peripheral smear, the earliest whistleblower in the mystery of blood disorders. As we all know that peripheral smear has been the bread and butter of all hematoppathologists, or for that matter, general pathologists throughout the country. And it plays a fundamental role. It's a fundamental window which gives us the insight of the entire spectrum of blood disorders, be it common diseases as well as some rare diseases which can be picked up right from the peripheral smear itself. So however, with today's newer technologies and with the invent of genetics and flow cytometry and much many more advanced techniques, the role of peripheral smear sometimes feels like a lost art. It feels like a forgotten diagnostic tool. But hopefully today, with today's session, these few cases will still help us highlight the importance of peripheral smear, and hopefully it will not feel like a lost art. So I'll be discussing 3 cases. I'll be starting with my first case. And this was a 16-year-old girl who was a resident of Meerut. She presented to our hospital, and she was already on a follow-up since almost a decade. And she was earlier diagnosed as an HS case, that is hereditary spherocytosis with ITP. However, there were no documents available, and she was on intermittent follow-up with history of chronic anemia. There was thrombocytopenia along with splenomegaly. However, there were no history of gallstones. The findings didn't seem really tandem with each other, and we digged up with the simple testing from our CBCs and peripheral smear and the biochemical examination. So initially, the biochemistry investigations were sent. Total bilirubin was slightly elevated, with indirect bilirubin being on the higher side. Our liver enzymes were normal to slightly deranged. Alkaline phosphatase was increased. In view of a chronic anemia history, we did do a DCT, which was negative. We received this CBC, and there was anemia, hemoglobin of 9.4. With mostly red cell indices showing a macrocytic picture with MCV of 110. MCHC was within the normal range of 31.2. RDW was increased. Platelet, which were further confirmed on the manual smear, were 96,000. And the immature platelet fraction, IPF, was greatly increased. It was 42.7. Usually we consider it normal within 7%. So this was much higher. And TLC was within normal limits. So, of course, we went ahead and saw the peripheral smear picture. So typically, when we see our peripheral smear, we look at all the three things, that is our RBCs, WBCs, and platelets, and of course, if there's any hemoparasite. So in this, we can see all the three things. We can see a reactive lymphocyte. We can see this one big giant platelet. And when we look at our RBCs, we can see this typical slit-like pallor, central pallor in most of our RBCs, which we usually refer to as stomatocytes. So I'll show you more pictures. There are these really big giant platelets. We can see they're bigger than the size of our RBCs. And in the RBCs, we can see those stomatocytes, those slit-like central pallor. Along with that, we can also see a few spherocytes, right? So these were the findings that we saw on peripheral smear. With her history that she was probably a case of HS with these spherocytes, we were confused as the morphology was not completely fitting into an HS because of the stomatocytes, and where did these giant platelets come from? So this is again another picture with these really big giant platelets and the stomatocytes in the background. We further went ahead to for completion of a hemolytic picture. We did the retic stain, and retic was increased. It was 9.9%, absolute retic count of 269,000, which is greatly increased. So these stomatocytes are typically derived from the Greek term, which is stoma, which basically means mouth. So it's like a slit-like, mouth-like appearance. Traditionally, we've seen that as kids when we used to study biology, that stomatocytes in plants have this appearance, and it can also be compared to the coffee bean appearance as well. So when we see these stomatocytes on peripheral smear, what all can we think of? So first, is it an artifact? Because commonly we can see stomatocytes which can just be an artifact and not a pathological reason behind it. So how do we prove that it's an artifact or it's a pathological cause of stomatocytes? Usually when it's an artifact, it's not there throughout the slide. And the reason behind this artifact is that there's either some changes in the pH while staining the peripheral smear, or exposure to certain cationic detergents, which can lead to dehydration of these RBCs and thus disappearance. So it is always, whenever we see stomatocytes on peripheral smear, it is always best to first again do a restaining to rule out these artifactual causes leading to dehydration and disappearance. And whenever we compare this to a pathological cause, we will always see a background of we will always see sorry yeah so we will always see the background of hemolysis. That is, we will see the polychromasia in the background, we will see the increased reticulocyte count on the retic stain, and there'll be a background of anemia as well. So that is how first, whenever we see stomatocytes on peripheral smear, we should always first look into the artifactual versus pathological cause. Once we know it is pathological, what can be the differential diagnosis when we see such things on peripheral smear? So there can be hereditary causes as well as acquired causes of stomatocytes. So in the hereditary, the most common is the hereditary stomatocytosis, which is again of mainly two types, overhydrated and dehydrated type. The overhydrated is the more common one, and it usually leads to the swelling of the RBCs and will lead to the hemolytic picture, anemia, and the MCHC is usually on the lower side. And when we perform an osmotic fragility test, it usually shows an increased fragility of the RBCs, and the mutations involved are commonly RUG type mutations. Whereas the dehydrated type usually shows the opposite effect. It will lose water. Instead of leading to RBC swelling, it will lose water, and thus the dehydrated term. And the most common mutation involved is PIZO1 gene. Then we have a term called cryohydrocytosis, which is usually a temperature sensitive condition in which the cells leak the ions in cold. And then there is a condition called cytosterolemia, which is a lipid disorder in which we can see stomatocytes along with macrothrombocytopenia. These are the hereditary causes. Then we have our acquired causes, which can be alcoholism, liver diseases, few drugs. It can be certain viral infections, certain malignancies. So in this case, once we saw the picture on the peripheral smear of stomatocytes, few spherocytes, we went ahead and performed an incubated osmotic fragility test. To our surprise, the patient who was being treated as an HS since 10 years was not an HS. There was no increased fragility of the RBCs. For that matter, it was normal to slightly on the resistant side as compared to the control, probably because of the increased polychromatophils in the background. Then again, we did EMA dye binding test, which is more sensitive for HS as compared to even incubated osmotic fragility test, and that also came out to be negative. So we completely ruled out HS in this case, and we were more confident on of the stomatocytes that we saw on our peripheral smear and along with the giant platelets. So we did give the possibility of an inherited stomatocytic disorder. We still have to rule out the other causes of hereditary stomatocytosis. And with the macro thrombocytopenic picture, provisional diagnosis of cytosterolemia was also suspected. And we advised further lipid profile, parental studies, and the molecular studies for the final diagnosis. In the meantime, till we got our genetic testing done, we took the parents' blood sample, we took the CBC of both mother and father, and we made the peripheral smear of both. And we could see that both mother and father did show stomatocytes. This is the PS of the mother with these giant platelets. And again, father, we can see a lot of stomatocytes with giant platelets. And on the CBC picture, mother and father, the platelet counts were mostly normal. Father slightly on the borderline, and the retic count was also borderline. I will not say elevated, but it was right at the border. And mother was slightly anemic as well. So this even again it iterated that yeah, there was the possibility of an inheritance. And however, both parents were asymptomatic. There were no any such symptoms in both the parents. And in the meantime, our NGS came up, and it was ABCG5 gene mutation, and it was a homozygous nonsense mutation, and that led us to our final diagnosis of cytosterolemia. So this is a condition which is not that common. Even for me, I hadn't seen a case. This was my first case 2 years back. And it was something new for me as well. When I saw the morphology, I had to go back to literature. I had to Google things up. And that is when I actually learned about this condition. So I will just inform you little highlights of this condition and why is it important to pick it up on peripheral smear. So it's an autosomal recessive inheritance. We saw both parents had a little bit of phenotype. However, they did not show any symptoms. And what happens in this condition is that there is increased GI absorption and reduced excretion of plant sterols. So these are not the cholesterol, the normal cholesterol that we see, but these are the ones that are derived from the plants. And most commonly, cytosterols are the ones that are involved. So normally what happens is that these ABCG5 and 8 gene is responsible for excretion of these plant sterols back within the intestine. It doesn't let it get absorbed within our body. But whenever there is this mutation in this ABC5 or 8 gene, these plant sterols that are absorbed by the intestine into the intestinal epithelial cells are not excreted back into the intestine, whereas they're absorbed in our body. It goes into the liver and further into our blood supply. So now these phytosterols, which are commonly hardly less than 5% in our body, once this mutation comes, these are increased markedly. And these these cytosterols are responsible for the pathogenesis that I'll describe further. Surprisingly, when I looked up at the prevalence of this disease and this mutation, it was quite high. The mutation prevalence was 1 in 200 in general individuals, and the homozygous component was 1 in 20,000 individuals. It seems very common. However, it is highly, highly underdiagnosed. I think we really need to tell people about this condition. We really need to tell because of the serious complications that are attached to this. What are the clinical presentations? So most commonly, because there is increase in these plant sterols in the body, there will be deposition of these sterols within the body, and most commonly they present with xanthomas. And these xanthomas can be on the hands, elbows, knees, and Achilles tendons above the heels. So these are the common areas where these xanthomas appear. Then the further complication part of these deposition of these sterols leads to further atherosclerosis and its complications at a very early age. At a very early age, I mean, is teenage to early 20s, which is a very early presentation of atherosclerosis. And then these cases can also show joint stiffness and pain because of the joint built-up of these sterols. And they can have some hemolytic component as well, which is not very common as compared to the xanthomas. However, because of these plant sterols, when they get attached to the RBCs, they can lead to the lysis of these RBCs and present as hemolytic anemia. And they can lead to destruction of platelets as well, and then thus leading to increase in the size of platelets as a reactionary change. And then thus, because of the hemolytic component, it can also present as splenomegaly. So, in our patient, there were no features of xanthomas. It was mainly a hematological presentation. And when I went through the literature, I could see few case reports similar, in which they were the presentation was that of a hematological manifestation than the xanthomas that we saw. Now, the importance now for these cases is that because these can be easily misdiagnosed as just chronic anemias, hemolytic anemias, and thrombocytopenias, like it was in our case, it can lead to delayed diagnosis, inappropriate treatments, and it will lead to delay in life-saving interventions, especially when there are complications like premature atherosclerosis, which can lead to early deaths. So, in general, what are the lab evaluation that we do for such cases after looking at the CBC and peripheral smear is that we can do the cholesterol levels, which usually are normal to slightly elevated. Then there are plant sterol levels that can be done, however, they are not commonly available. CBC and peripheral smear is our biggest tool. Then we have the hemolytic workup, which will include your bilirubin levels, reticulocytes, LDH. And the genetic testing is the nail in the coffin. That is the final diagnosis that will help us. Differential diagnosis based on presentations of xanthomas can be familial hypercholesterolemia, Danger's disease. Then we have cerebrotendinous xanthomatosis, familial hypertriglyceridemia, beta lipoproteinemia. But however, all of these conditions will have higher cholesterol levels as compared to cytosterolemia. And so we need to pick these cases because even the treatment differs from a typical familial hypercholesterolemia, which is usually statin treatment. And sadly, these cases do not respond to statin treatment. So that is why it is very important to pick these cases up early to avoid all these complications, which can include atherosclerosis related coronary artery diseases, MIs, and premature cardiac deaths, and even liver diseases. Once the diagnosis is made, there are two, three things that we have to uh, tell the patients. One is a major lifestyle recommendation. There are dietary changes that have to be incorporated to avoid these plant sterols altogether. And they're commonly, these plant sterols are part of avocados, chocolate, some vegetable oils. Then there are certain nuts that have these plant sterols, certain seeds and legumes and shellfish. And there are certain products that are labeled as fortified with sterols. So we have to give them a full dietary chart as to what all they cannot eat so as to help them lead a normal life. And in terms of treatment, as I said, statin is not the first line of treatment in these cases, whereas ezetimibe is one of the treatments which will help us to lower down the sterol levels in these cases. Bile acid sequestrants can also be used. Statins not as a first line, but certain cases which do have increased cholesterol levels as well. So statins can help us reduce that component. And one really important thing in these, because as I said, it's an autosomal recessive part, is one genetic counseling for the family is required so that we can test at-risk relatives. And there is annual surveillance for development of any further complications. We need to look at their CBC levels. We need to look at the non-invasive imagings for their cardiac health, calcium scoring, echo, etc., so as to keep an annual surveillance so that they do not develop any of the complications that can be life threatening. So this was one case that we published 2 years back, and Yeah, so this is one case that just with morphology, we can pick it up and it can be life-saving for the patient. So, coming to the next case. So this is a 12-day-old baby girl. She was referred to our center with history of yellowish discoloration of eyes since day 3 of life. And she was already admitted to local hospitals for these complaints, received phototherapy, again went back home. And in her history, it was a full-term elective cesarean section. There was no perinatal events and there was no significant family history. So we received the initial workup. The bilirubin was high. It was all indirect bilirubin, which was 19.95 milligram. And LFTs was predominantly normal. LDH was on the higher side. We received the CBC. The hemoglobin was low. It was 8.2 and with an MCV of 109, which is okay for the age. Platelets were fine. TLC was fine for the age. And then we received our peripheral smear. So once I looked at this case, it was interesting. Usually, uh, s- newborns, the RBC picture is very nice and sweet, normocytic cells to macrocytic cells, a lot of polychromatophils in the background. However, in this case, very unique morphology was visible. I'll highlight these RBCs. These are typical hyperdense, contracted red cells. We can see these throughout the peripheral smear. These are contracted, hyperdense cells, spiculated margins with. So these cells are described as pycnocytes. I'll show you many morphology, many photos so that it gets settled in your mind. Like whenever you see these cells, what are these? These are not typical schistocytes. They don't have a very well-defined sharp margin, right? These are not typical fragmented cells. So these all cells would, and they were very, very prominent throughout the picture, throughout the peripheral smear picture. There were many of these pycnocytes. And then we went ahead, we did the retic count, and in the retic, it was obviously increased. It was 16% with an absolute count of 3,72,000. And in addition, we saw these Heinz bodies. So a peripheral smear showing those pycnocytes and a hemolytic background with the retic being increased and these Heinz bodies. So it does raise a suspicion that there's some sort of a oxidative stress-induced hemolysis happening in the patient with indirect bilirubin being so high. And so we did an extensive workup to rule out what all conditions can lead to this. So obviously for Heinz body, there's G6PD deficiency that we will think that came out to be normal. We did a DCT which came out to be negative. We ruled out an ABO incompatibility that was in there. We did the PK levels which were normal. And incubated OFT was also performed, keeping in mind to rule out other causes. Everything was negative. And because we didn't really have an answer, and with this picture and knowing one entity which exists, which is called infantile pycnocytosis, we thought let's do the whole rapid exome sequencing because it was available at our center, and we sent the sample for that. It was not available at center, but we sent it for the patient's family was willing to take out that much money, and that also came out to be negative. There was no clinically significant variant, showing towards any inherited cause of hemolytic anemia. And then we did raise a suspicion that this might be an infantile pycnocytosis, which is a benign condition, a self-resolving condition. And the patient was kept on follow-up, given symptomatic treatment for high bilirubin. Phototherapy was given, blood transfusions were given whenever the hemoglobin dropped too much. And this is the chart that we made in the next follow-ups over the 4 months. Total bilirubin levels started decreasing from 19.9, and it was a declining trend. And within 4 months, they were back to normal. The indirect bilirubin was back to normal. Hemoglobin levels had a little bit of lower trend, then we gave the blood transfusion, and then again declined and then further stabilized. And by the 4th month, it was 11.2. Retic count, again, it was on the declining trend with few transfusions in the middle, and eventually it came back to normal. So we could see a spontaneous remission within 4 months. So this again confirmed our diagnosis. What we suspected initially was of infantile pyknocytosis. Now, what is infantile pyknocytosis? Again, it's not very common. It's a rare condition. So I'm bringing it up today. So it is basically a non-immune cause of hemolytic anemia, which usually presents with jaundice and hemolysis in initial few days of life, and it is characterized by these transient appearance of pycnocytes, which are the hyperdense contracted spiculated red cells. And the condition, interestingly, is self-limiting. It resolves within few weeks to months, and it has been, the literature says that it does account for around 10% of unexplained neonatal hemolytic anemias. However, it's really rare right now. When I went and dig the literature, I could find few case reports, one or two small case series. Around about globally, 100 cases have been defined so far. And it is likely underdiagnosed because of the limited awareness, and as there is no defined criteria for it. So it still remains very underdiagnosed, and it, I'm sure, must be adding a lot of toll to the pediatricians and to the patients' families, like a small baby and you don't have a diagnosis till it actually, self limits in few months. So yeah, there is again importance. There is a need for telling, especially young pathologists and the hematopathologist, including at the peripheries, the pathologists at peripheries, to pick up these subtle signs so that we can get to a cause. Typically, infantile pyknocytosis does not have a defined cause right now. We don't know why it occurs. On pathophysiology, probably what has been linked is that there's some extravascular process which leads to the oxidative stress of RBCs, and that is supported by the presence of Heinz bodies, which also disappear once it resolves. And few factors have been associated, which include some kind of a perinatal stress that led to this oxidative stress, including respiratory distress. Prematurity can be one reason because there's an immature antioxidant system when the baby is born premature, and there's vitamin E deficiency, which can lead to RBCs being more prone to stress. There's no known genetic mutation so far. So, as of now, it is considered as a diagnosis of exclusion. We do have to exclude the common causes of these conditions. And right now, we do not have a very predefined what all we have to rule out. But according to the presentation, we have to exclude various causes, which includes our ABORH incompatibility, the red cell enzymopathies, membranopathies, unstable hemoglobins. We have to exclude all these causes. And usually, these patients have a spontaneous remission within 3 to 6 months of age. And the diagnostic triad that has been defined is the pycnocytes on peripheral smear, and exclusion of other causes, and eventually the self-limiting course. Heinz body is not 100% times associated with it, but it has been seen in many cases. So, investigations required will be the typical peripheral smear, retic count, and the hemolytic workup, DCT to rule out the immune causes, and all the other conditions that I just discussed. Management is supportive care, phototherapy to prevent any kernicterus, and then blood transfusions if there's severe anemia, and a close loop until there is resolution. So this case again is, it just highlights that it is rare so far, maybe underdiagnosed because it is not that known. It's not written in the book so far. There's only few case reports, hardly 100 so far globally. And thus, it doesn't have a very standardized diagnostic criteria. Results vary according to the case reports. And thus, it emphasizes the crucial role of our peripheral smear in diagnosing such morphology driven diagnosis. And this will definitely help these small babies to reduce the burden on the NICUs to prevent kernicterus, right? So we have to, and also to, for the parents, especially, with these young kids, to tell them that it's okay. Hopefully, if we've ruled out all the other causes and this condition is known, let's just keep a follow up and so that there is a self-limiting course. And yeah, we need more cases to be reported, so that we have more deeper research on such cases, so that it'll help us understand the pathogenesis more, the potential causative factors. And you never know, we actually have a cause for it which is just unknown to us right now. It's just the tip of the iceberg for us, and maybe there is something deep underlying there, and time will tell what it comes out to be in future. So that was my second case, and now I'm coming to my last and final case for tonight. So this is a 70-year-old male, known case of diabetes, hypertension, CKD, presenting with gangrene of digits, and along with that, a renal failure kind of a picture. So CBC came to the lab, hemoglobin was reduced to 7.7, MCV, RBC was fine, RBC was on the lower side, TLC slightly elevated, platelets also normal. On the DLC, slight left shift was there, but nothing significant. And then we saw our peripheral smear. Here it is. So we can see these pinkish purple colored globules. They were more common on the edges of the smear, but these were very evident throughout the smear. And there was a background of rouleau formation as well. Again, this is at the edge where I can see these globules. And if I think next picture will be a better highlight, yeah. So in this, you can see this WBC, a neutrophil, which has actually ingested one of those globules. It's a very interesting morphology and typical of something that is not that common and not that commonly seen on peripheral smear, which is cryoglobulins. And we prepare once we saw that smear, we incubated that sample at 37 degrees Celsius, suspecting that if it's cryoglobulins, it should disappear, and that is what exactly happened. The smear prepared after the incubation showed the resolution of those pale colored deposits, and all those globules were not seen anymore. So the qualitative test that for cryoglobulin that we use is we have to incubate the sample at a temperature less than around 4 degrees Celsius, which leads to the appearance of these cryoglobulins, a gel-like substance, and which can again dissolve once the temperature is again brought to 37 degrees Celsius. I'll show this in further. So for our case, after seeing cryoglobulins on peripheral blood, we had to further, subclassify as to what it is. So we saw the further testings, and the serum cryoglobulins were increased. The C3 levels were slightly low. C4 were near normal. We did the viral markers, hepatitis B, C, HIV, all were negative because there was a CKD component and renal hematuria presentation. So there were renal function test also showed increased creat, increased urea. Then to further further jot down the real further subtyping of this. And there was a rouleau formation in the background. We wanted to rule out a myeloma background, so or any other lymphoproliferative form. So this is the bone marrow that we saw. You can see in the background again all those bluish purplish globules throughout the marrow. They were extensively seen throughout the marrow, and there were these plasma cells along with it. So I'll show you more pictures. This was the florid cryoglobulins that I could see on the bone marrow. The smear were full of it. And of course, when you see it at a low power, you think, is it just, some artifact? Or are these platelet clumps or blood clots? And when I went to the higher magnification, no, these were those similar globules that I could see on the peripheral smear with these immature plasma cells. These immature plasma cells in the marrow were around 15-20%. So further to see the clonality of these plasma cells, we did the flow cytometry. And yes, they came out to be clonal. So these were on 38-138 plot. We picked up these plasma cells. They showed kappa restriction, loss of 19, 56 positivity, 27 on the dimmer side. So yes, these were clonal plasma cells, which helped us with the peripheral smear picture, with the bone marrow picture, to reach to the final diagnosis, that is type 1 cryoglobulinemia. So what is cryoglobulinemia? Okay, I'll come to that again. So further diagnosis was helped by our myeloma panel. On SPE, we could see an M band. On IFE, it was an IgG kappa band. And even renal biopsy was performed. And that also showed presence of cryoglobulins with kappa fixation, similar to the bone marrow, that is kappa. So what are these cryoglobulins and what is this disease entity? So these cryoglobulins are actually proteins that precipitate in individual's serum or plasma at temperatures lower than 37 degree. So when our normal body temperature is fine, when the atmosphere, the weather conditions are fine, usually these proteins will not precipitate. But whenever the temperature lower downs, these proteins start precipitating. What are these proteins? So these are, it can either be a mixture or immunoglobulins themselves. So it can be either a mixture of immunoglobulins along with complement components, or just the immunoglobulins like in type 1, that is the one associated with myeloma. So what these cryoglobulins do are that once they get precipitated, they get deposited in our vessels, small or medium size, throughout the body, causing endothelial injury and end organ damage. It's not a very common condition. It's a rare condition, and usually 1 in 1 lakh individuals have this significant cryoglobulinemia. And higher prevalence is there in colder conditions. They precipitate more than in Southern Europe. So there is this one classification which is a landmark for this. It's a Broad criteria, which divides it into 3 subtypes. Type 1, which was our case, has a clonal cause behind it. It is usually a lymphoproliferative disorder, either a B cell lymphoma or myelomas or MGUS, which lead to formation of these immunoglobulins, which are clonal, and these clonal immunoglobulins can precipitate when the temperature is lower. And then there's type 2 and type 3, which are also called as mixed cryoglobulins. So the causes behind these are various viral infections like hepatitis C, hepatitis B, HIV, autoimmune diseases, and again, some B cell lymphoproliferative disorders can also come as the mixed cryoglobulins. And in this, what is the mixture? In type 2, the immunoglobulins, there's a mixture of monoclonal as well as a polyclonal immunoglobulins, whereas in type 3, these are all polyclonal along with complement system. So as I described, the causes are the same, and rheumatoid factor can be associated with type 2 and type 3. There's autoimmune diseases involved. And when we do the C4 levels, the complement 4 levels, they are usually normal in type 1 because they are not involved in the pathogenesis, whereas in type 2 and type 3, they are reduced because they get, when they form the immune complexes, so the free value of C4 would be reduced. In hepatitis C, the pathogenesis involved is that viruses always play the viral mimicry component of their antigen expression. And what they do is they interact with B cells through the CD81 receptor, which further leads to activation of these B cells. And then they further interact with plasma cells, which leads to the formation of immunoglobulins, which can be polyclonal, like in type 3, then oligoclonal or monoclonal antibodies. And then these immune complexes that are eventually formed, they come and attack either the RBCs or the endothelial cells throughout the body, including the blood vessels or in the kidneys, which lead to the further damage. There have been various triggers for mixed cryoglobulinemia. As I said, the viral infections are common, but there are other infections like for certain bacterial infections, parasites, funguses. I will not go into the details. So what is the typical clinical manifestation? It can be divided according to the subtype. The type 1 cryoglobulinemia, the presentation is mostly because of the hyperviscosity or the thrombosis. So it can present as acrocyanosis, Reynolds phenomena, digital ulceration, purpura throughout the limbs, and retinal hemorrhage. So these are the manifestations in type 1. Whereas in type 2 and 3, it usually involves the blood vessels. So there can be purpuras, there can be peripheral neuropathies because of the immune complexes being deposited. There can be skin ulcers. There can be damage to the kidneys. And so mainly it involves skins, joints, nerves, and kidneys. So for lab diagnosis, of course, I've shown you like we could see on the peripheral smear itself those cryoglobulins, and then we have a cryoglobulin test further so that we can see that how those clumping gets precipitated at 4 degrees Celsius and how once we rewarm it, it resolves. We can do the complement, we have to do the complement assay, especially to further divide the subclassify the types. Rheumatoid factors play the role. Then we have to do the viral studies. Then we have to do the protein electrophoresis, SP and IFE, again to further subclassify if it's a clonal background. Then we have to do the renal function test, liver function test, ANA to for the autoimmune background, ESR, as we know it is increased in myelomas. Then urine analysis for the kidney damage. We can do the imagings for involvement of the organs. Then we can do the nerve testing for the peripheral neuropathies. We can do the serum viscosity. So all of those are a lot of tests that we have to do to further subclassify. But one important part is that the cryoglobulin test, which is basically what we have to do is, so one important fact in this case is that uh, we have to maintain that temperature chain. So whenever we suspect a cryoglobulin, right, or we've seen it on CBC or peripheral smear, or we have the clinical manifestation, so we know that we are suspecting cryoglobulin. So one thing we have to do is whenever we collect the sample, especially to do this cryoglobulin test, we have to make sure that the tubes are pre-warmed. Keep it in a water bath. Whenever you go for the sample collection of the patient, the tubes should be at 37 degrees Celsius. And we take, and there should be no anticoagulant in that tube. And we collect it at maintained temperature of 37 degrees Celsius. And after collecting the sample, we allowed it to clot to remove the serum. We centrifuge it at again 37. We have to maintain the temperature. After that is when we keep it at 4 degrees Celsius and then we allow it to precipitate. So now the time that it takes for the cryoglobulins to precipitate also helps us to further subclassify. If it is type 1, the precipitates is done within 24 hours. Max, it can take in some conditions up to 3 to 5 day window, but usually within 24 hours, we see the precipitate. Whereas in type 2 and type 3, it is usually longer time. We have to keep the sample at 4 degrees Celsius for 5 to up to 7 days to see the precipitates. So this is how the precipitate would look like at cold temperature. It's like a white jelly-like thin. And once we again keep the sample at 37, we can again, after rewarming, see that there's disappearance of that cryoprecipitate. And we can do a repeat centrifugation to determine the cryocrit of these cases. Then there are certain spectrophotometric analysis which can actually tell us the concentration of these cryoglobulins. And of course, we have the specific immunological assays like IFE, SP to determine the clonality of these cases. Then we can do biopsies. Like in our case, we did the bone marrow biopsy for an underlying lymphoproliferative disorder, myelomas or MGUS. We can do skin biopsy to establish if there's any vasculitis. We can do kidney biopsy, which is most commonly seen as a membranoproliferative glomerulonephritis. So this is a very busy slide, but mainly highlighting the renal pathology in cryoglobulinemia. It's mainly it is a membranoproliferative pattern, and we can see some pseudothrombi. I will not go into too much details. This is the skin manifestations in which we can see the vasculitis pattern. And treatment again will depend on what type it is. So if it's of type 1, we'll treat it accordingly. If it's a type 2, if it's an infection, an autoimmune disease, the treatment will depend completely on that. So coming to the end of the session, so do we still think that peripheral smears are a forgotten diagnostics tool or they're a lost art? I don't think so. They still are really important. They still have a lot to tell. They can be whistleblowers to really morbid conditions. So these three cases, I just wanted to highlight that their peripheral smear will still always be important, and even in this era of automation. And picking these conditions on peripheral smear will lead to the early diagnosis and treatment, especially in which cases, unsuspected cases in which we are not even thinking of certain conditions, but peripheral smear will completely guide you in a direction that you were never expecting, the clinicians were never expecting. And it will always be our core skill. It is our powerful diagnostic tool, and for both common as well as morbid conditions. So, yeah, instead of saying that it's a lost tool, we should be elated and enthusiastic to pick up and recognize these conditions. So, that is the end of my topic. Three cases highlighting the importance of peripheral smear. And I hope none of you slept through this. So, I am just going to just ignite your minds again. So, here is a quiz time. This is just
Dr.
one.
Surbhi, just before the quiz, let's take a
Yes.
breather so that
Okay.
they get to refresh their mind before actually coming up with the answers for the quiz. First of all, let me
Okay.
congratulate you on an amazing presentation. It was definitely like putting the thinking cap on, as they say, and looking at peripheral smear or hematology practice itself in a very different perspective. There are
Yeah.
hosts of take-home messages that I could, derive from your presentation. The first and
Yeah.
foremost being that clinical correlation is so important even to today. Nothing
Yeah.
goes beyond that, right? And the second thing is we all think that the peripheral smear is a very common test, and we sometimes do take it for granted, but there are so many clues that actually come up from that. And it is so important to have that awareness to examine that smear in a right way and to have the perseverance that even if there are certain things that you are unaware of, to actually delve deep and dig deeper, like how you did in these three cases. And perseverance always pays, and you do find those answers. And not only that, it opens the doors to a vista of directions that you can take in the right way in order to do the consecutive tests, which are more relevant to that particular case, instead of going on a wild goose chase, right, with the patient as well as ourselves. And the another very important take-home message, it's about not working in a bubble. Even though we are hemat experts, it's not about confining ourselves to hematology. You have to correlate with other lab parameters. Biochemistry throws in a lot of other clues as well, which gives you even more foresight as to where the case is heading to. And not just biochemistry, as you rightfully showed out over here, flow cytometry, obviously, wherever is pertinent, and if you have that tool in your practice, and even histopathology for that matter, and things like electrophoresis, where you have demonstrated the M band, which is very relevant in that particular case, and also the demonstration of light chain restriction monoclonality seen in the renal biopsy. And that's kind of corroborative, and that's the way to work in present time, so that you don't end up being, in a bubble and constricting yourself into not opening up your mind to think of what other differential diagnosis could really be there. And it's also about keeping abreast with all the recent advances that keep coming up, listening to talks like yours, which, throws a different dimension as to what we can do in practice. And I'm sure that today's participants will really enjoyed this session thoroughly. Thank you so much, Dr. Surbhi Singh. So we are open for interaction. If you have any comments or questions regarding the first three cases that Dr. Surbhi Singh has mentioned, we are ready to take that up. Or we could finish the quiz, since everything is still
Mhm.
fresh in your memories. We can do the
Mhm.
quiz and then take up questions
Yeah.
in the end.
Yeah. Okay. So the quiz is actually a spotter, and it is unfortunately not related to these three cases. It is
Right.
just a spotter that we can pick on peripheral smear. So I will just show it. So please recognize the organism seen on the peripheral blood film of a patient with a recent history of travel to America and now has presented with fever. So I've given the four options. Is it Plasmodium? Is it Anaplasma, Babesia, or Eldridge? I will give hints. We can see these parasites kind of in a ring forms, some showing amoeboid appearance. These are these clusters. These are, of course, extra RBCs. And then few we can also see within the RBCs.
Well, we're getting a lot of responses in the chat box. There is anaplasma, somebody calling it, and there are two other people who are calling it babesia. Anybody else wanting to take a shot? Because we're just going to give a couple of more seconds for this. So this is a spotter, shouldn't take too long as we've all had our it's very nostalgic when you think about our own exams and we always had a spotter slide, right? So here it goes. A couple of more seconds, guys. Take your pick. All right, another answer of babesia. All right. So I think we're going to stop the taking the answers right now. Okay.
We have quite few winners over here. Nice. So I'll just show
Yes.
the answer.
Please let us know the answer. Well,
Yeah.
that's right.
Yes,
So
it
it
is
is babesia.
Yeah, so commonly the pathognomic feature that we call is the Maltese cross, which is these four Babesia ring forms that are seen. And one of the closest differentials is actually Plasmodium falciparum ring forms. And we have to differentiate. There are various ways we can differentiate. There's lack of hemozoin pigment in Babesia, and the morphology is slightly different. They are more amoeboid forms, and we will not see the gametocyte forms of falciparum in Babesia, of course. So yeah, there are ways that we can differentiate, and it's not that common. It's not so, it's endemic there in America and other countries, not common in India. So whenever there's a travel history and we see such morphology, it's important to know things that are not common in your area, but obviously with today's world people are traveling, so we will see things that are not common here but are common elsewhere, so we have to keep our minds open to that.
Absolutely agree with you, Dr. Surbhi. There's one person in the chat box and it's mentioned as iPad. It would be nice if you could share your name so that we know who is giving this answer and that we can connect with you as well. Please do mention your name, whoever is signing up from the iPad and given us the answer. Congratulations to all the people who gave us the right answer. That's very good thinking, and that was very quick on the fingers as well in order to come up with the right diagnosis. So I hope the quiz was exciting, and we will be giving a special gift to all the people who gave us the right answer. I would really like to thank our speaker, esteemed speaker today. Again, a heartfelt thanks to you from me and on behalf of SigTuple. To you, Dr. Surbhi, for making our evening really special today. I must say, a very different perspective, and I'm sure you found it inspirational. It was igniting our senses, and it gave a lot of food for thought, on how we could actually go back tomorrow and look at our blood smears again. And I don't think it's going to be the same way for a lot of people who have been hearing your talk. Are there any comments or any kind of questions or just anything generally that you all have to say regarding anything, if something like this you have encountered in your practice? Go ahead, please.
Hello.
Yes, ma'am. Dr. Indira?
Yeah,
Yes.
yeah. Thank you for the very interesting cases. I think this is the first time I'm seeing so many rare cases. The thing is, I had one doubt with the cryoglobulinemia.
Yes, ma'am.
How did you differentiate from the cold antibodies?
Cold antibodies. So, ma'am,
Because that's very common, isn't it?
yes. So in cold antibodies, what we see are that the agglutinations that we see are actually RBCs that form those clumps, the agglutinates
Yes.
that we see. So those are
Yes.
actually RBCs that clump together. Whereas in this, the RBCs were fine. There was some rouleau formation, but I could see these globules, which were not RBCs, but some protein deposits which were there. So on morphology, we could differentiate that. Of course, I understand the doubt because in cold agglutination, again, when we incubate the sample, the agglutinates disappear, but those agglutinates are formed from the RBCs and not these proteins that were seen in this case.
Because we encounter more of cold agglutinins.
Yes, yeah.
This is the most common one. So cryoglobin, I've not come across.
Yes, ma'am.
There are cases maybe hepatitis C is more commonly associated.
Yes.
It is present with joint pains usually. So just wondering that's
Yes, ma'am. So I've
because
seen both.
Coombs,
Yeah. So
Coombs test thing that would also help, I think.
Help. Yes, ma'am. That will help. Further testing will definitely help. Yes. Holmes test will come positive. We'll do the
Yes,
DCT. We
yes,
can do the
yes,
monospecific Holmes test for further.
yes,
But yeah,
yes,
on the smear itself, the
yes.
agglutinates will help. The
Yeah,
RBC
that's what,
agglutinates versus the
that's,
proteins.
yeah, that's what I was thinking. I
Yes.
saw
Yes.
those clumping, so I was wondering
Yeah.
whether there was
Yeah.
another that
Yes,
was
ma'am.
coexisting.
Mm-hmm.
Okay, okay. Thank you so
Yeah.
much.
You're welcome, ma'am.
Thank you, Dr. Indra, for your questions as well as your feedbacks and inputs. Any more questions from the audience out over there? If you cannot come on the video or on the call, you can even type it on the chat box and we'll be happy to answer that.
Yeah, thank you, Dr. Renu, for conducting such an interesting session.
You're welcome, ma'am. That's the whole reason we are here with this kind of webinar or educative series. The idea is to get the reality and the practical reality of what are the problems that we encounter in our lab, the challenges that we have, and such interesting cases as well. And what better platform than to share on something like this, which makes it not just educative, interactive, and also fun. We hope that all of you enjoyed the session, and we'll wait for just a couple of seconds more to see if anybody has any questions. You're welcome, Rohit Kumar. Rohit just said thank you on the chat, and most happy to be engaging with you. Anything else from anybody else? The videos are always available. We'll be happy to share the videos across. Do share it with the rest of your colleagues, the students, or anybody else who's interested in hematology practice. And knowledge grows. Shared knowledge is the best thing, right, which actually grows. And we're very happy to be part of this collaboration with all of you. And thank you so much on behalf of SigTuple for taking time out on a busy Friday evening. Thank you, Dr. Surbhi, as well, for taking a busy time out from your lab and being available at such a notice, in the evening on a busy Friday with us.
Thank you, ma'am.
Yeah, and
Thank you, ma'am. And really, all the three cases are very interesting.
Thank you there. Thank you for your feedback. So we will definitely be in this endeavor, in this spectrum, to see how beautifully we can come up with such seminars as well as sessions for the benefit of everyone. I'm sure we'll be seeing more often. Dr. Surbhi, we will be definitely hoping that you do come on our webinar and participate more often, and we look forward to that as well. On behalf of SigTuple again, thank you very much. And